Good morning, everybody. It's again a pleasure to be here in this conference. And I thought today I'll share some of the work that we've done over the last year about perhaps a different perspective of how we look at polypoidal choroidal vasculopathy, a little bit different from what we've been talking about with geographic atrophy, but still very much in line with the theme of imaging. So I think how we've diagnosed and looked at PCV for years is really with the use of indocyanine green angiography. And we're all very familiar with the Everest criteria, early hyperfluorescence with the nodular appearance. On colors, you have orange nodules, sometimes accompanied with massive submacular hemorrhage, and of course, a hyperfluorescent ring. And this gives us an amazing on-fast view of the lesion itself. Of course, then, with the advent of OCT and cross-section, we then start to talk about looking at these lesions from a different perspective, right? So we're looking at this cross-sectionally now. And we describe signs like a sharp peak PED and ring sign, and of course, we published this nice paper looking at how we can differentiate PCV from non-PCV lesions with the use of OCT and without ICGA. Now, so we have an on-fast view of the lesion. We have a cross-section view using OCT. What happens when we start to think about merging these two views together? So on-fast, of course, looking at things from the top down, and cross-section with our OCT. Do we have the technology to do that now? Yes, we do. So when we think about wanting to look at these lesions from a different perspective, we need to have several requirements. First, we need to visualize in high resolution blood flow within the lesion. We need to have the ability to depth resolve this, and we need to have some post-processing. Of course, this technology comes in terms of OCT angiography. Specifically, for this bit of work, we use the Plexilite. We use some of the algorithms available to us on the RE network and some of the post-processing tools in-house in the reading center. We're going to go through very quickly the methods of how we did this. So we had to do 3 repeated 3x3 OCTA scans on the Plexilite. We then used algorithms within the network to register and remove some of the artifacts. And we did some post-processing in terms of segmentation and, of course, the final 3D reconstruction of the lesion itself. I think we are familiar with this view. So this is a standard depth-resolved OCTA that you can get on most machines. It gives you different color codes at different levels within the OCTA. This is a 3D reconstruction with OCTA. And if we segment out the lesion itself, here you can see the polyp and the 2 wings of the branching vascular network. Now, the neat thing about having 3D reconstruction, of course, is then we can begin to visualize these lesions as a movie, so dynamic instead of something that's static. So here we can see really the conformation of these lesions and how they look like, looking at them from different directions. So this is one of the examples. This is what we can see with using these particular techniques. Here are 3 other lesions of PCV that we reconstructed. And of course, then, besides the fact that it's nice pictures on a stage, what can we learn from these 3D reconstructions? So first of all, I think we then verify what we know, that PCV lesions have a multiplanar configuration. So you have the polypoidal lesion that's sitting above the branching vascular network. And this is very nicely appreciated on these 3D reconstructions. Now, if we segment out the polyp itself, so take away the branching vascular network and just look at the polypoidal lesion, here we begin to see the architecture of the polypoidal lesion itself. And what is most striking, perhaps, is that you don't see the flow signal within that lesion. Instead, what we observe is a spiral coil-like internal architecture. And you have these little nodules on this spiral coil-like structure. So not the entire thing is a polyp, but rather something that's going around this space. I'll get to that in a second. So we see the cross-section view on OCT, and then we see the ring sign. And if we correlate that ring sign with what we see on ICG, you find that that ring correlates very nicely to that hyperfluorescent spot on ICGA. So what we did was then we segmented out this ring, and that's segmented there in blue, and we overlaid this on our 3D reconstruction just to see where exactly this ring was sitting. And as you can see, looks nice up there. You can see the ring sign really sits within that coiled architecture, and it really is a space within that coiled architecture. Blown up views here in relation with ICG as well as cross-section OCT. So here, again, we can appreciate that really it is this coil going around a space rather than the space itself being the polypoidal lesion. Let's look at the branching vascular network. So if we compare the branching vascular network on these reconstructions on PCV and a type 1 MNV, we see that a lot of the PCV lesions actually have a very large trunk vessel. And so this was what we found, that most polypoidal lesions actually had a large trunk compared to our type 1 MNVs, which had much finer vessels. And we think that this goes to the idea of some level of chronicity with the branching vascular network and the development of the polypoidal lesion. So completely speculation here, but the polypoidal lesion could be a result of a much more matured MNV, if you like, under the RPE. So we take it all together, a multiplanar configuration, which we know exists. What perhaps is interesting is the spiral coil-like internal architecture rather than a large polypoidal lump, with focal nodular bits around the coiled architecture, and of course this matured or hypermatured branching vascular network that we notice. So I'm going to leave you with this last picture here. So this is the 3D reconstruction with the polypoidal lesion, branching vascular network, the space outlined in blue, the ring lesion if you like, and overlying that, the green RPE, really showing very nicely, very neatly the configuration and how this lesion itself looks like on the retina. I'm going to advertise APVRS at the end of the year, November. Today is the last day for abstract submissions, unfortunately. But if you can squeeze one in, I'd be very happy to see you in Singapore in November. Thank you very much.
Thank you so much, Kelvin. And yeah, I mean, this paper was really interesting when I read through. I had a couple of questions about this work which you did that, you know, many times we all see PCV very frequently, especially this part of the world, but unfortunately, most of these PCVs tend to be hemorrhagic. So my first question to you is that how many times you were successful in reconstructing in these patients? I know, very tough one.
So I qualify to say that to do one of these reconstructions takes probably about 2 to 3 hours. So probably not clinically applicable at the moment. But you'll be surprised. We did have, so we ran a little bit of an investigator-initiated trial of about 50 PCVs, and we managed to reconstruct a vast majority of them. Now, granted, because it was a trial, we didn't include a lot of very hemorrhagic polyps. But I think when you get to a point where it's hemorrhagic, perhaps the treatment is different, and we might not require to know the configuration anymore.
Where do you see this getting applicable in terms of managing these patients?
So I think it gives us a good understanding of the lesion itself and potentially its etiology. So there could be implications like, for example, identifying feeder vessels. I think Giovanni Storenghi many years ago popularized this idea of lasering feeder vessels, so potentially something like that. In itself, what we're doing now is looking at the longitudinal changes of these 3D reconstructions. So these eyes that I showed had treatment over a year with anti-VEGF. It'd be interesting to see what happens to these eyes, to these lesions over time.
Yeah, and as you know that I have interest in getting the 3D reconstruction of choroidal vessels, and I always wish that, you know, we could actually link these network with the choroidal vessels. Did you try doing something like that?
The fundamental problem with this is with lesions, everything under becomes very difficult to define on OCTA. So I'm not 100% sure the accuracy of the choroidal vessels under the lesions and whether they'll be visualized correctly. Hence, you know, the difficulty in combining these two techniques. Well, Jay, if you have a good solution, I'll be happy to work with you on it.
Yeah, we should talk about that. Thank you so much. Any other questions for Kelvin? Any comments? George?
good to see this. Have you looked at? You showed the configuration of a cluster of polyp, and you talked about the feeder supplying it. But there are other configurations of PCV, polypoidal lesions, where you see these multiple bulbs at the end of, another pattern is you see the tiny polyps with the BVN, and some of them, without any feeder. So have you looked at the other patterns? Because this is like typical clustered one, which behave differently to treatment as well. And these doesn't respond to anti-VEGFs more, these kind of lesions. So have you looked at the other configurations? And I feel there'll be different patterns when you do the reconstruction.
Yeah.
Quick answer.
Yeah, I agree. I think we did get very different configurations. We didn't have the resolution to see those little aneurysms on the coils, but we did see smaller coils in those particular subtypes that you were talking about.
We have Dr. Holder. We brought him in the imaging meeting, so let's see what his question is. A quick one.
It's a technical question, Kelvin. Very, very impressive images, which require a huge amount of software and assumptions within that software. Now, if you take one set of images in one particular patient, and then you repeat the whole process on that same patient, what's the retest variability within the image construction? Because it seems to me that there's so much going on, there's going to be intrinsic variability in the way the software deals with certain processes at certain stages.
Yeah, I have to admit that we didn't reconstruct the images, but with OCTA, I would say that you capture most of that information at that time point, and it's not dynamic enough that I think there'll be a lot of difference with different time points.
Because it's important, if at any stage it becomes therapeutically useful, you've got to have the accuracy which is demonstrably replicable.
Thank you. Great question. Thank you so much. And with this, I would end the GA session. And it is very nice to see there was so much interest in GA, especially in India. And I think we all are excited to see what's coming up. Thanks a lot, and we will move on to the next session.